Okay. Good evening, faculty. I'm Dr. Tanvi Vasalla. Today I'm presenting a case related to the hypertensive disorders of pregnancy. Ma'am, am I audible?
Yeah, I can hear you,
Okay.
Tanvi.
Mrs. X, 36-year-old female, resident of Nandgaon, Baroda, married to Mr. Y, shopkeeper by occupation, Hindu, homemaker, educated, belongs to the upper middle class according to the modified Kupop-Swami scale. She has an obstetric score of G2P1L1 with previous cesarean section. Her LMP is 21 August 2021 and EDD is 28 May 2022. She presented with chief complaint of amenorrhea since 8 months and came to the OPD for routine antenatal checkup, and her blood pressure recording was found to be high. History of present illness. The patient came to OPD for the routine antenatal checkup. Her BP was found to be high and she was further admitted for evaluation. She was perceiving adequate fetal movements. There was no history of any headache, blurring of vision, chest pain, decreased urine output or excessive weight gain. There was no history of pain in abdomen, leaking PV or bleeding PV. History of present pregnancy. First trimester, it was a spontaneous conception of a non-consanguineous marriage. Her LMP 21st August and her EDD 28th May 2022. There was no history of irregular cycles. She was sure of the date. She was diagnosed at 1.5 months of amenorrhea by UPT. She was booked at a government hospital at 2 months of period of gestation, and she was advised antenatal investigations, which were normal. Dating scan was done, which was normal, and she was advised 1 yellow tablet to be taken regularly, OD. There was no
So,
complaint. Yes,
Tanvi, I hope you don't mind if I interrupt you. So,
no,
you've
no,
written
please.
advised antenatal investigations, which were normal. So, what are the routine antenatal investigations do you think would have been advised at 2 months when she went?
So, ma'am, we'll first of all go to blood group cross matching. Then we'll go for hemoglobin, anti-hematocrit platelet count. Then screening for serology, HIV, HbSAg, VDRL. Then urine routine microscopy, RBS, and PT, APTT, INR.
Do we routinely recommend PT, APTT, INR in all women in pregnancy?
Not routinely, ma'am, but we do it sometimes.
Okay, all right. Okay, so you said hemoglobin, you said blood group RH typing, you said viral markers, you said urine routine microscopy.
And ma'am, sickle cell as well.
Routinely, do we screen for sickle cell?
Ma'am, yeah, not in all patients, but if they have a history.
Okay, what else? What other investigations do you want to get in the first trimester?
Ma'am, sonography.
Okay, now I'm talking about blood or urine investigation.
So, ma'am, urine culture can be sent.
Yes, so urine culture should be sent. Why should urine culture be sent?
So, ma'am, pregnancy, the chances of infection like UTI. So, to rule out any kind of infection.
Okay, so what is that called? What is that called? Urine infection in the absence of any symptoms.
Asymptomatic.
So why is it important? Why is detecting and treating asymptomatic bacteriuria? Why is it important in pregnancy?
Ma'am, because it may cause ascending infection and can further get complicated.
So how many pregnancies do you think would get complicated if we do not treat asymptomatic bacteriuria? How many will end up with symptomatic bacteriuria?
Sorry, ma'am, I don't know.
So about 20 to 30% of women will eventually land up with UTI. That's why it's very important to treat asymptomatic bacteriuria. Okay, one more investigation you would advise in the first trimester, especially in our country, because we're endemic for that. Someone has written in the chat box. So Dr. Siroj has written thyroid profile, right? So we basically don't, so we don't do an entire thyroid profile. We do a screening
serum
with
TSH.
Yes, we do a TSH screening in the first trimester, preferably in the first trimester for all pregnant women, because we are endemic for goiter. So hypothyroidism is very, very common in India. All right. So those are the antenatal investigations, right? Please continue.
In the second trimester, quickening was felt at 3 months of amenorrhea. She was perceiving adequate fetal movements. 2 doses of tetanus toxoid were taken at 4th and the 5th month. She was vaccinated for COVID as well, both the doses with the booster.
I'll interrupt you again here. You said 2 doses of tetanus toxoid have been taken. What are the newest guidelines regarding tetanus immunization in pregnancy? 2018, things have changed. Most
Yes,
places
ma'am.
we now give, what do we give now?
DT now, we give DT followed by TDAP.
Okay, so we give, what does the government of India say? The government of India says TT should be replaced by TD, tetanus and
TD,
diphtheria.
diphtheria.
How should it be given?
Uh,
Okay, so it should be given the same as TT, the first dose as early as possible and the second dose after 4 weeks. Okay.
4 weeks. Yes, ma'am.
TDAP, should we be giving TDAP or not? And if we should, when should we be giving TDAP?
Ma'am, we should be giving TDAP and it should be preferably given in the last trimester.
So TDAP is recommended by the ACOG. It's not yet recommended by Ministry of Health and Family Welfare, but yes, if TDAP has definitely a better protection because it protects against pertussis also, and it should be given after 27 weeks of gestation. What are the
Okay.
other immunizations you would advise in pregnancy
Ma'am,
nowadays?
influenza,
Influenza, yes. More
COVID,
important, yes.
Covishield.
Always. So now, Asha, you've mentioned it. I just saw vaccinated for COVID as well. Very good. So now in your histories, all of you, please start mentioning the status of the COVID vaccination. Good, you've mentioned it. Okay, continue.
Ma'am, second sonography was done at 5th month and the findings were to be normal. The lab investigations were repeated in the second trimester and they were found to be normal. There was history of regular intake of all the yellow, red and white tablets. There was no history of any high BP recording, no history of signs like epigastric pain, blurred vision, headache, decreased urine output or swelling of feet. There was no history of any excessive hunger and thirst, any frequency of micturition or recurrent UTI. There was no history of easy fatigability, breathlessness, dyspnea on exertion, palpitation, syncopal attack, and chest pain. And there was no history of fever, burning micturition, bleeding per vaginum, or leaking per vagina.
All right.
Third trimester, she came on her first visit in third trimester for a routine antenatal checkup. Her BP recordings were found to be high. The recordings were repeated after giving her rest and they were still found to be high. She was admitted for further surveillance and there were no other complaints accompanying the high blood pressure, like complaints of epigastric pain, laryngophagein, headache, chest pain or dyspnea. Ma'am, menstrual history, age of Minaki was 14 years of age, and she had passed regular cycles of 3 to 5 days, which were repeated in 30 days. There was no history of dysmenorrhea and passage of clots, and she used 3 to 4 pads per day.
So what is the period of gestation? Maybe I missed it. She is how many weeks?
32 weeks, 5 days.
32 weeks and 5 days. All right. So with hypertension. Okay.
Yeah. Ma'am, her obstetric score is G2P1L1. Previous was a lower LSCS, cesarean section. She has an 11-year-old male child. It was a full-term pregnancy. LSCS was done due to fetal distress. There were history of high BP recordings in term. Treatment was done with oral antihypertensives and BP was maintained. Intrapartum and postpartum was uneventful. The child's exclusive breastfed for 6 months, fully immunized and having showed normal developmental milestones. She did not take a contraceptive after that. Past history is not significant. In family history,
what should you ask in past history?
Ma'am, any past history of if she is having hypertension before or any other disorder
so
like thyroid, jaundice, or any history of blood transfusion or history of tuberculosis and any medication she's taking, diabetes, and any surgical history.
Okay, all right. Specifically because we're talking about hypertension, anything else you want to ask?
Hypertension. Basically, ma'am, any antihypertensive she's taken before.
Okay.
Or ever she has done a regular BP follow-up.
Okay, so you have to ask
any complaint of headache, any complaint of regular headaches.
Okay, so since she was a diagnosed hypertensive in her last pregnancy, we need to know whether the hypertension was, whether she ever got herself checked postpartum or not.
Yes,
okay, why is that important?
Ma'am, because postpartum, if the BP was still high after 12 weeks, then it could be chronic hypertension and she need to be taken medication. Also, she should have avoided pregnancy for a longer period of time.
She's already avoided for 11 years.
Yes, ma'am. In case we knew that if we could counsel her previously, so we could just see if her BP is already maintained or not.
Okay, all right. Continue.
Ma'am, personal history. Okay, family history. History of hypertension in the mother. In mother, 10 years back, and that was also controlled by oral antihypertensives. Personal history: adequate sleep, bowel bladder habits normal, no history of any addiction, and there is no drug addiction as well. Dietary history, she takes a mixed diet and her consumption is 2500 kilocalorie per day with 62 grams of daily protein. On general examination,
okay, so based on her history, what are the important points? Can you just tell me the important points in history we have?
Yes, ma'am. So first of all, her age, she's a 36-year-old.
Okay, so age is important. So age itself is a high risk factor. She's more than 35. What else?
Yes, ma'am. Then again, she has a previous cesarean section, though it was an obstetric indication, fetal distress, but still.
Okay, right.
Then,
so she has second risk factor is she's a previous scarred uterus. Okay, then third.
Third, ma'am, history of hypertension in the family.
Okay.
And
third,
history of hypertension in previous pregnancy.
Right, good. What
and too much interval between both the pregnancies.
That's very good. The interval is more than 10 years. So when the interval is more than 10 years, they tend to act like a primigravida. Okay, so that becomes an important risk factor for, again, developing hypertension. All right, so these are the risk factors. So she has several risk factors. So very important, remember, don't neglect the age. The age is very, very important. Okay, family history is also very, very important. So even if she didn't have a history of hypertension or in her previous pregnancy, these three, her age, her inter-pregnancy interval, and the family history itself put her at high risk of developing hypertension. Okay, continue examination.
Okay, ma'am. On general examination, the patient was sitting comfortably. She was conscious, well-oriented with time, person, and place. She has a average build and she is well-nourished. General condition is fair. Height is 152 centimeter. Pre-pregnancy weight was 72 kgs. Present weight is 80 kgs, and her BMI is 34.6. So, ma'am, she is obese as well. Yeah, and then hydration was adequate.
This is the pre-pregnancy BMI?
No, ma'am. This is the present one.
So always calculate the pre-pregnancy BMI. The pre-pregnancy BMI is the one which is important. Okay. Also, the current weight gain in her pregnancy. So her pre-pregnancy weight, is 72 kg. Using that, recalculate her BMI. Okay. So always, if she knows her pre-pregnancy weight, calculate her BMI pre-pregnancy and her weight gain in this pregnancy. So the weight gain in this pregnancy is 8 kg, which is normal or abnormal?
Ma'am, approx it should be 11. If the weight gain is more than 1 kg per week or more than 3 kgs per month, then we take it as abnormal, but this doesn't seem to be abnormal.
So again, it depends on the BMI. So if she is a very thin lady, then even a lot of weight gain, even up to 15 kg weight gain in the entire pregnancy is considered normal. But if her BMI is more than 30, even 6 kg is considered sufficient. So it has to, so that's why the pre-pregnancy BMI is very important. You need to calculate that.
Okay, ma'am. Ma'am, pre-pregnancy BMI in this case was around 30 point something.
Right. So 8 kg also is, and she's just 32 weeks. So she will tend to gain more weight. And so it's just borderline. Her weight gain is just all right. Okay.
Okay. Hydration is adequate. She's afebrile on touch. Pulse rate is 84 beats per minute in right radial artery with good volume, normal character, no radiofemoral delay. All peripheral pulses are palpable. The blood pressure was 160 by 110 millimeter of mercury in right arm in supine position, which was repeated after 15 minutes. In both the arms, the BP was 160 by 110, and even after repeating after 15 minutes, the BP was same. The mean arterial pressure was 115. And respiratory rate was 18 per minute, thoraco-abdominal. JVP was not raised. Normal hair texture, orodental hygiene was fair. No pallor, icterus, cyanosis, or clubbing. Grade 2 pedal edema was present. Lymph nodes were not palpable, and bilaterally the breasts were normal. On systemic examination, respiratory system, cardiovascular, and CNS all were normal. They did not show any deviation from normal. On abdominal examination or inspection, the abdomen was uniformly distended. Uterine ovoid was in longitudinal axis. All quadrants moving well with respiration. Umbilicus was central and inverted. Linea nigra was present. Stria gravidarum was present. There were no dilated veins. Previous caesarean scar was present. It was a transverse, low, suprapubic scar of around 10 centimeter, which healed well. Palpation, all inspectory findings were confirmed. Local temperature was not raised. SFH in fiber fundal height was 30 centimeters. AG was 92 centimeters. And uterus corresponded to 32 week size. It was relaxed. Longitudinal lie, cephalic presentation. Uterus relaxed, non-tender. Liquor was adequate. Effective fetal weight was around 2 kgs. And previous cesarean scar was present. There was no scar tenderness. On auscultation, the fetal heart sound was present on the right spino-umbilical line, which was regular, 142 beats per minute. Per speculum not done, per vaginal examination was not done immediately, and urine albumin was done. So dipstick pit it showed urine +2. Summary: 36-year female with obstetric score of G2P1L1 with previous cesarean section, with history of hypertension in previous pregnancy and family history of hypertension, with grade 1 obesity, with raised mean arterial pressure, period of gestation being 32 weeks 5 days, with single live fetus in longitudinal lie cephalic presentation, with preeclampsia with severe features, not in labor, with BP readings of 160 by 110, with pedal edema of grade 2 and gestosis score of 6.
What is gestosis score?
Ma'am, gestosis score is devised by FOGSI. It consists of all the risk factors related to pregnancy, including all the history factors from the history. So they are divided into mild, moderate, and severe. Severe, the scoring is 3, moderate is 2, and mild is 1. And if a score is more than 3, then we can consider her to be a high-risk case for preeclampsia.
All right. So Tanvi, tell me what you already outlined the high risk factors. So
Yes,
you've highlighted them very nicely. It was a very nicely presented case. Okay, so now she's 32 weeks and you've diagnosed her to have severe preeclampsia. So what would you want to do now?
Ma'am, first of all, we'll admit her for evaluation since the BP is still high above the line. Cut line of 160 by 110. So we are considering it to be a severe preeclampsia case, which might get into eclampsia. So for management, first of all, we will admit the patient for maternal and fetal assessment, and immediately we will the approach should be including 3 things. We'll first of all try to lower her hypertension, then we will try to give a seizure prophylaxis, then we'll consider giving a corticosteroid, and then we'll try to plan the termination of pregnancy. So under 4 headings we'll try to consider.
Okay, so the first heading you said was we'll admit her and we will, what did you say we will?
Assessment, and we'll do assessment.
Okay, so how will you assess her? She already has one feature of severe preeclampsia, that is her blood pressure itself, right? 160 by 110. So what are the other features? What are the other things to say to severe preeclampsia?
Ma'am, with or without proteinuria, but we should be looking for end organ damage in the form of any visual disturbances, low urine output, headache, epigastric pain, or bilateral crepes are present. So any sign which shows the end organ damage, there we will consider it to be severe.
All right. So proteinuria is no longer an essential criteria, right? So otherwise, if we want to assess the proteinuria, how do we do that?
So ma'am, for proteinuria, we take a 24-hour urine sample. Earlier it was taken. First sample was discarded. From the second sample, we take it. In the common clinic OPD, we simply do the urine albumin dipstick, which is, if it is like +2, we take it more specific, because then this thing false positive rate is much less with a +2. And then apart from that, we do a serum protein creatinine ratio. And if that ratio is more than 0.8, we consider it. More than 300 milligram per
more than
24.
30, more than 30. 24 urine protein more than 300 milligram, but serum protein creat ratio more than 30.
More than 30.
Serum albumin creat ratio, I think, is 0.8.
More than 0.8, yes.
But if you take a protein creat ratio more than 30, just 30. Confirm this, it should be more than 30. All right. So we do no longer, what is important to remember here, those who are listening, is that 24 urine protein is no longer required. In fact, proteinuria itself is no longer required to diagnose preeclampsia if there is presence of or evidence of end organ damage. As she said, if there is evidence of renal affliction, how do we check for kidney? What are the different tests we do? How will we investigate this patient further?
So, ma'am, first of all the normal ANC tests that we do, we'll do a BP recording 4 hourly. Apart
Okay.
from that, we'll do
Investigations,
an
yeah.
LFT, RFT.
LFT, good.
So first
Okay.
of all, hemoglobin hematocrit. Then we'll go for LFT, RFT,
Yeah.
blood group cross matching,
Yeah.
and serum LDH, alkaline phosphatase, serum uric acid. And apart from that, if she is showing any signs of abruptio or bleeding anywhere, so then we can go for the coagulation profile as well. We'll do a sonography. We'll do a fundoscopy examination, and yeah, peripheral smear. Peripheral smear is
Okay.
basic. We have to take for science to check for hemolysis.
Okay. So you've outlined all the investigations very nicely. So just to repeat, we will do a kidney function test. In the kidney function test, what is important to remember is that urea and creat. So what are the normal values of urea and creat in pregnancy? Are they lower compared to non-pregnant or higher? What is the value taken?
Ma'am,
Cutoff value.
creat is bit high.
Creat, the value is higher, is taken higher or lower in a non-pregnant compared to a non-pregnant individual?
Ma'am, 0.7 to 0.9, I think.
So the upper limit is taken as 0.9. All right, it's
Okay,
slightly
0.9.
lower compared to a non-pregnant patient. Right,
Okay,
Dr.
ma'am.
Saroj is also mentioning 0.8. So 0.9 is the cutoff, and urea also we take the cutoff slightly lower compared to a non-pregnant patient. What
Okay,
are
ma'am.
the others? You mentioned liver function test. In liver function test, what do we look for?
Liver function test, we'll look for serum bilirubin, indirect
Yeah.
bilirubin. Then we'll look
Yes.
for SGOT, SGPT.
Yeah.
And apart from that, serum transamin, SGOT, SGPT, serum bilirubin. Ma'am,
You're right.
that's it.
So why are these important?
Ma'am, these are important because if the value is high, we can consider it to be going into HELLP syndrome.
Okay. What is HELLP syndrome?
Ma'am, HELLP syndrome is hemolysis along with elevated liver enzymes with low platelet count.
Okay, so
And it
how,
is
so hemolysis is evidenced by, as you said, a drop in the hemoglobin or a rise in the indirect bilirubin
LDH.
or LDH. So whenever red cells are destroyed, they will release LDH. So suppose this
Yes.
patient is 32 weeks, and suppose you do her LFT and you find that the enzymes are raised, you do an LDH, you find it's raised. So she's in HELP syndrome. What would you want to do?
Her enzymes are raised and she's in HELLP syndrome. So, ma'am, for HELLP syndrome, we usually consider, we don't have an expectant management and we usually consider termination of pregnancy as the best treatment.
Right. So HELP
So,
syndrome would
we,
be termination of pregnancy. Would you want to do something for this patient before terminating?
ma'am, first of all, corticosteroids need to be given to for the lung maturity of the baby.
Anything else? So you're terminating at 32 weeks. You'll give her corticosteroids. Anything else?
32 weeks. We are terminating her to.
HELP syndrome.
Ma'am, platelet transfusion would be required.
Okay, if depends on the platelet count. What
Count.
else? 32 weeks. What are you worried about at 32 weeks? You're given corticosteroids, but you're still worried about a preterm infant. So what can you give?
Maxulf.
Yes, you can give magnesium
Neuroprotective.
sulfate. It will act as a neuroprotective
Neuroprotection
agent. Right.
agent.
Good. So what can you tell us about neuroprotection and magnesium sulfate?
So, ma'am, magnesium sulfate is considered to be neuroprotective in preterm babies, and it reduces the risk of leukoencephalopathies in the child. And the dose is considered to be same as the dose of anti-seizure prophylaxis, like 4 gram IV.
Okay, so would you want to give this woman anti-seizure prophylaxis?
Definitely, ma'am, because she is one patient who can, because of the lab findings which we are getting, she
Okay.
might be a case of eminent eclampsia. So it's better to give a.
So how would you give anti-seizure prophylaxis for her?
So, ma'am, anti-seizure prophylaxis will give magnesium sulfate. We'll use the Pichard regime itself.
Okay, so can you tell us about the Pritchard's regime?
So, ma'am, Pichard regime has both IV and IM component. IV is always given 20% by weight, and IM is given 50% by weight. So, we will give 4 grams over IV over 4 to 5 minutes slowly, and we'll give 10 milligrams. We'll give 10 grams, 5 grams in alternate buttock IM injection. This is the loading dose, ma'am. In the maintenance dose, we will give 5 gram IM every 6 hourly, and we will look for signs of toxicity if they are.
So what signs will you look for?
Ma'am, we look for deep tendon reflexes. Then we look for the respiratory rate to be more than 14. And we also look for urine output to be more than 30 ml per hour.
Why do we look for urine output?
Ma'am, because MAGSALF is basically excreted through the kidney. So if it might lead to deterioration of the renal function and might lead to renal failure as well.
Okay, so if renal failure is there, then magnesium won't be excreted and that will lead to magnesium toxicity. Okay, good. Okay, so suppose this patient had come to you and you were in the antenatal OPD at say 10 weeks with this history of hypertension and 11 years back cesarean. So would you have wanted to do something at that time? If she had come to you or you were in the hospital that
yes,
time?
ma'am, I would like to start her on aspirin.
Okay,
And
why?
calcium as well. So, ma'am, it's been seen that all these patients in which there is chances of preeclampsia, there's history of preeclampsia, hypertension. If aspirin is started in around 150 milligram OD, the chances of patient going into eclampsia is reduced by 4 times.
Okay,
Around
so this patient,
65%, yeah.
So can you exactly tell what is the protocol? When do we start ecosprin? You said 150 milligram. Can you tell us in which category of patients we will start ecosprin? Who are the high risk patients we should start ecosprin?
So, ma'am, any patient who has hypertension, patient having any connective tissue disorders, those having APLA, and any history of bleeding if they're presented with.
Okay, so the high risk factors are if she has a previous history of hypertension, like this patient in her past pregnancy, if she has chronic hypertension, if she has APLA or SLE, if she is a case of diabetes, then you would want to give this patient, or if she has chronic kidney disease. So these 5, you would want to immediately start ecosprin with even a single risk factor. Okay. What are the moderate risk factors? That means, so if a single high risk factor is present, you will start ecosprin, or if 2 or more moderate risk factors are present. What are the moderate risk factors?
So, ma'am, moderate risk factors again include diabetes, multi-fetal gestation.
She has a multiple pregnancy, right? If she is a primigravida, if her
she is a primigravida, she has any chronic vascular diseases, and if she is obese.
Okay. Or if her age is more than 30.
30, yes, ma'am. And there is excessive weight gain during pregnancy.
And like in this patient, if her inter-pregnancy interval is more than 10 years.
More than 10 years, yes.
So if she has multiple moderate or 2 or more moderate risk factors, again, you would want to start her on ecosprin. Right. Yeah. So, okay, suppose a patient comes to you, she's a primary low risk, otherwise seemingly low risk, but she says, my mother has hypertension. I'm very worried that I may develop hypertension in this pregnancy. So how can you predict whether she will have hypertension or not? Is there any way?
Yes, ma'am, there are predictor scores we have. We have that, yeah. So there we have a screening for early preeclampsia.
Just tell me how can we screen? And don't tell me practically what all will you look for or what all can be done.
So, ma'am, we look for maternal history we've taken. So we look for second would be uterine artery pulsatile index.
Very good. So you'll do a Doppler. So you have biophysical markers and you have biochemical markers. In biophysical, we have an ultrasound. And as you said, we will look for a uterine artery pulsatility index. What will happen to the PI?
Ma'am, it will be raised.
So yes, why will it be raised?
Because, ma'am, resistance is increased in the
very good. So whenever there's resistance in a vessel, the PI, the pulsatility index rises. Why will there be resistance in the uterine artery?
Ma'am, because there is failure of the second wave of trophoblastic inversion.
Good. Okay.
In cases of preeclampsia.
Right. So uterine artery PI is increased. And what are the biochemical parameters we check?
So we have, ma'am, PAP-A and placental growth factor.
What happens to them?
Ma'am, they also rise.
So PAP-A and placental growth factor will reduce, will go down, will decrease in women who are prone to develop preeclampsia or women who have developed preeclampsia. The levels are down. Remember, the one starting with P, their value goes down. PAP-A, placental growth factor go down. What goes up? I think someone's written in the chat box. The SFLT, the soluble tyrosine kinase, what is his name? SFLT and soluble endoglin. There are 2 parameters which go up. and the placental growth factor PAPA go down. So based on these, the history, the risk factors, the biophysical and the biochemical markers, there are different scoring systems which will assess the risk. And if the risk is more than 1 in 100, then we always start the woman on prophylactic
Aspirin.
75 to 150 milligram is the recommendation. Okay. All right. So this patient with this history, suppose we do her investigations, everything comes normal. Okay. How will you want to monitor her, or what would you want to do?
Ma'am, we will try to keep her for 2 to 3 days for monitoring before discharging her. We'll ask her
Blood
to
pressure is 160 by 110. What will you want to do?
First of all, ma'am, antihypertensive should be given.
Which antihypertensive will you
We'll
start?
start her on labetalol 20 mg IV over 2 to 3 minutes, and then we'll wait for 20 minutes. We'll repeat the dose to be next dose to be 40, and again assess after 20 minutes, then again 40 and 80. So one cycle we can give 220 minutes. If she's responding well to labetalol, then we can continue that. And if she's not responding well, then we can switch her to the other antihypertensive. We can give her either hydralazine or we can give her nifedipine. And
so labetalol we can give, hydralazine we can give, nifedipine we can give. What can't we give?
Lasix and all. Diuretics we cannot use.
What is the indication for giving Lasix? We can give, but in which indication?
Ma'am, in case of severe pulmonary edema.
Okay. In case of pulmonary edema, we can give Lasix. All right. So what about alpha-methyl-dopa?
Ma'am, alpha-methyl-dopa is obsolete now, means they usually don't use it now.
Why?
Ma'am, because it causes postpartum respiratory depression.
Postpartum respiratory depression.
Oh, sorry, postpartum depression. Sorry.
Causes postpartum depression, yes. So when we were PGs, it was the drug of choice. So when you say obsolete, it makes me feel very old now. Yes, so alpha-methyl-dopa is still used. Yes, it is going out of use because labetalol is now the drug of choice. But alpha-methyl-dopa has a very excellent safety profile.
Okay, ma'am.
So it is very, it has no teratogenic effects, completely no fetal neonatal effects at all. But yes, it causes postpartum depression. It also causes postural hypotension. And the biggest disadvantage is that its onset of action takes 12 to 24 hours. Okay, so it takes a long time for the initial onset of action, whereas labetalol has a much quicker onset of action. So that's why labetalol is preferred. Why don't we use other beta blockers?
Ma'am, because this has a selective alpha beta blocker action. Others might lead to hypoglycemia, hypotension, tachycardia.
Okay. What fetal effect can other beta blockers have?
Ma'am, they can cause fetal bradycardia and
long term. Say a patient is chronically hypertensive on atenolol. Why won't we continue it?
Ma'am, because ma'am, it
can cause long-term use can cause fetal growth restriction.
Fetal growth restriction.
Okay. Yes, ma'am. All right. So this patient coming to FGR, this patient, the fetus looks all right. Clinically, you said uterus corresponds to 32 weeks. If isochondrite was good, fetal weight is good. How will you assess the fetus now in this patient?
So, ma'am, we'll ask the patient to do a DFMC. And on the first visit, we'll go for growth scans routinely per week. And then we'll also do a non-stress test at admission. And we'll do a biophysical profile once in 2 weeks.
Okay. Anything else you want to do? What are the recommendations? What is the best?
Fluid, ma'am, in the sonography, you look for the fluid
volume. You mentioned BPP, that is a part of BPP. Anything else? So what is the recommendation? What should be what is the best method for intrapartum, for antepartum fetal monitoring and preeclampsia? Apart from serial growth scans. There is no FGR in this patient, but what else would you want to do?
Ma'am, CP ratio.
So you'll want to do a Doppler. Of the umbilical artery. So umbilical artery Doppler is recommended. Since you mentioned CP ratio, what is CP ratio?
Oh, ma'am, CP ratio is pulsatile index of MCA upon the pulsatile index of uterine artery. And if it is more than
uterine artery, no, it is the pulse of the umbilical artery. So
umbilical artery, sorry.
So it is the PI of the MCA, ratio of the PI of the MCA and the umbilical artery. So what is the normal value?
So, ma'am, if it is more than 1, it is considered to be good. And
Right.
if it is less than 1, we'll say that
There is
the
redistribution.
fetal
All
rate.
right.
Yes, ma'am.
Okay. All right. So, um, suppose this patient goes into labor, or you induce this patient, say she develops uh, signs of severe preeclampsia, or suppose she goes into HELP syndrome and you induce this woman at 34 weeks. So,
Yes,
what
ma'am.
are the intrapartum precautions you would take?
Ma'am, intrapartum, ma'am, we'll first not try to take her for trial of labor because she's a previous cesarean, but yes,
Okay, okay, yes,
high
right,
risk.
correct.
But
So
if
I
we
missed that. So
induce,
suppose she was a previous normal delivery.
yes, ma'am.
Then we induce her. What are the precautions we would take?
Ma'am, first of all, intrapartum, the second stage of labor need to be cut down, and we need to first
In all
this.
women, in all
No, ma'am.
preeclampsias, we'll cut
No,
short the
ma'am.
second stage.
Ma'am, in the HELP syndrome, if we are considering,
Okay,
if
let's talk
any,
about first stage of labor. First, let's go
okay.
stepwise. First stage of labor.
So, ma'am, regular BP monitoring needs to be done along
Okay,
with
good.
fetal monitoring every 5 minutes,
Right.
every 15 minutes. And then, ma'am, cross-match blood groups should be done beforehand and blood should be
Good.
ready. And
Okay, what
then,
else?
uh, pre- ma'am, we need to see her BP is in control and we
That
have
you
to
told me.
restrict the fluids.
Yes, very
We'll
good. So
start her.
very important point is restrict the fluid intake. Encourage oral intake. Avoid intravenous fluid overload. Very important point. And one more very important point.
Ma'am, methargine is to be
That is in
contraindicated.
the second stage. First
Ma'am,
stage, first stage. First stage, what important point would you want to take care of? What can cause a rise in blood pressure?
ma'am, any stimulant.
What, when she's in labor, she'll be having, she's in labor, so
Uh,
she'll be having pain. Pain can
pain. Yes,
cause,
ma'am. Yes,
pain
ma'am.
itself is a stressor. It increases her blood pressure. So what can we do? So
We can
adequate
give her anesthesia can be given. Pain relief,
analgesia.
adequate
Yes.
analgesia can be given.
Yes, even epidural anesthesia can be given. Patient should receive adequate pain relief.
Pain
Okay,
relief.
then second
Uh,
stage.
Ma'am, intrapartum stage, we'll try to cut, if the patient is in stress, we can try to cut down the second stage of
If her
labor.
blood pressure is controlled, you don't have to cut short second stage of labor. Only if her
Okay.
blood pressure is shooting up, then you cut short second stage of labor. So she's 34 weeks. How will you want to cut short second stage of labor?
Ma'am, she's preterm. So, ma'am, I'll prefer a forceps delivery over a ventouse.
Okay, so where else will you prefer a forceps or a ventouse? The other
Uh,
indications where you will prefer a forceps or you won't use a ventouse?
Ma'am, if it's a preterm, rather ventouse is better.
Preterm, yes. Preterm forceps is better, yes. What else? Where else is forceps better? In other words, what are the contraindications of vacuum delivery?
Contraindications of vacuum.
Is where you would prefer a forceps, obviously.
Yes, ma'am. Ma'am, face presentation.
Very good.
Bro presentation, any
Bro would
malpresentation.
not deliver anyway. Bro won't deliver, so don't answer bro. Bro does not have a mechanism of labor. Face you
Yes,
won't use
face.
a vacuum. Obviously, the Chignon won't form.
Yes,
Where
ma'am.
else? Where else won't a Chignon form?
Ma'am, breach means any mal apart from
Okay,
vertex
breach
kind of.
also, if the after coming head you can't use a vacuum, you'll use a forceps. But where else will the Chignon not form?
Ma'am, deflexed head. Sorry, ma'am, I don't know. Sorry.
In an intrauterine death, if there's fetal demise, a Chignon won't form
Will
if
not
you use
form.
a vacuum. So again, forceps will be preferred. Any condition where you don't want the mother to bear down, like if she's
Cardiac,
having a seizure or
cardiac,
cardiac
cardiac
disease, you prefer
disease.
a forceps because
For,
vacuum also always requires maternal bearing down efforts. Okay, so in conditions where you don't want the mother to bear down, in conditions, and this I'm talking about where the station is, where everything is favorable for either forceps or vacuum. That means station is low, and rotation has happened. I'm not talking about high forceps, I'm talking about outlet forceps versus vacuum. With everything else being the same, you will prefer forceps in a woman who doesn't want to bear down, who you don't want her to bear down, or a woman who has face presentation, or if it's a fetal demise or a preterm. These are the conditions where you will prefer a forceps over a
for a
vacuum.
ventouse.
Okay.
Yes, ma'am.
All right. So we'll cut short second stage of labor. What is the other precaution you had mentioned? You would want, what won't you give in the second stage?
Ma'am, methargine is contraindicated because
Methyl
that.
ergometrin. Where else will you not give methyl ergometrin? Other contraindications of methyl ergometrin.
Ma'am, any cardiovascular disorder.
Okay. Cardiac disease. Or where else?
Ma'am,
Other contraindications.
allergy.
Methyl ergometrin. Usually that's for prostaglandins. Methyl ergometrin will not. You won't find allergic reactions. Other contraindications to methyl ergometrin.
Twins.
Yes, after the birth of the first twin, you should not give methyl ergometrin, and also in RH negative pregnancies. Okay, because what happens when there's vasoconstriction of the vessel caused by methyl ergometrin, some amount of fetal blood goes back into the maternal circulation, and that can lead to fetal-maternal hemorrhage. Okay, or mixing of blood. All right, so 4 conditions where you don't give methogen, you should know these. Okay, third stage, what will you do in this patient? What are the important things to remember?
Third stage of labor, ma'am. In the third stage, ma'am, the stages of active management of labor will be.
You'll do active management of third stage of labor. So what will you do as part of active management of third stage of labor?
Ma'am, fundal massage will be given, and we would, ma'am, in this case, we can do early cord clamping.
So if the fetus is distressed or you're expecting neonatal asphyxia, then yes, otherwise delayed cord clamping is the rule. Okay, there is no indication unless there is fetal asphyxia or fetal distress, then only you will do an early cord clamping, otherwise delayed cord clamping. What else? Delayed cord clamping, what are the other components of active management of third stage of labor?
Uterotonic to be given.
Yes, and, which uterotonic will you prefer in this?
Ma'am, oxytocin only.
How much?
Oxytocin, ma'am, 10 units in one pen.
10 units intramuscular, or if she has an IV cannula, 10 units
in
IV infusion. Okay, yes, then what else? What else can be given in place of oxytocin?
Ma'am, carboprost can be given.
Carboprost can be given, but what does the WHO say? WHO say in AMTSL, what are the drugs of choice? You can give oxytocin, you can give methyl ergometrin. In this patient, we won't give, obviously. What else can be given?
Ma'am, we can give a misoprostol.
We can give misoprostol. How much and how?
Ma'am, 600 to 800 microgram per rectally.
Okay, what else? What is the newest drug which has been recently introduced, even in India now? It's recently being used many places. What is a synthetic analog of oxytocin, which is stable at room temperature? Syntocin is oxytocin. Sintometrin is oxytocin plus methyl ergometrin. I'm talking about a new drug, relatively new drug, which is now being used in many centers for prophylaxis of PPH, not treatment. Prophylaxis of atonic PPH. Have you heard of carbetocin?
Carbetocin, yes, ma'am.
Carbetocin. You should know about carbetocin. It is one thing which is definitely going to be asked in the exam. Okay, carbetocin has now been approved by the WHO for prophylaxis of atonic PPH. What are the advantages of carbetocin? The biggest advantage. It is stable at room temperature. Oxytocin, you need to maintain a cold chain. Carbetocin is stable at room temperature. So the WHO says where cost is not an issue, when there's no, when it is not proving to be expensive to the patient, then carbetocin should be given in place of other drugs because carbetocin is stable at room temperature. Okay, so read about carbetocin. That's important. Okay. This patient, what will you advise her post she's delivered? She had suppose we did a cesarean section for her. We call her after we discharge her. When will we call her next?
So ma'am, we'll call her next week, and before going, we'll counsel her that she should get her BP checked. First of all, we'll see if the BP is normal or not before discharge.
So how often will you check her blood pressure before discharge?
Before discharge, ma'am, again 2 times a day.
More often than that, we check the patient's blood pressure at least 4 times in the first 24 hours, and then at least 2 times in a day. Okay. Then
Ma'am, apart from that, then we'll counsel her to, we'll repeat the blood test again after 2 days, after 48 to 72 hours, so that we know if the values have come back to normal or not.
Okay.
And before discharging, we'll counsel her that she needs to get her BP checked every 2 times in a week. And if oral antihypertensives have to be given, she need to continue that till the target BP of around 140 to 90 is raised. And we'll ask her to follow up next week. Like,
Okay. So suppose she comes at 6 weeks, her blood pressure is still high.
ma'am, then we'll refer her to a physician.
Okay.
To
When
see
will
if
you
it is
call
chronic.
her? Okay, so you will call her as chronic hypertension when? If the BP is persistently
Less
high
than 12
after?
weeks. Less
After
than
12
weeks.
weeks. Okay.
Yes.
She asks for contraception. What will you advise her?
Ma'am, contraceptive, we'll try to avoid the hormonal ones because she has a
Which hormonal
vasogenetic
ones?
disease. DMPA we'll avoid, and progesterone only pills also we'll avoid. We'll rather go for an IUCD and along with barrier method. And we can give her Centroman if her LFT comes down to normal values.
All right. Can you advise her? She's like, I want a LNG IUS.
Yes, ma'am, we can.
That can be advised.
But
Okay.
we'll
How
wait for
soon?
at least 6 weeks.
After 6 weeks. All right. So good, Tanvi. I think we can end here. Very good presentation. Thank you so much.
Thank you so much, ma'am.
You have any doubts, you can ask me. Anyone else has any doubts?
Ma'am, one doubt I
Yeah.
have that
Yeah,
you
yeah.
mentioned about the aspirin dose. So is it like it has to be moderated between 75 to 150, or is it a fixed dose that WHO has
So I'll
recommended?
tell you. So the RCOG says it is given it is mentioned 75 to 150 milligram, whereas FIGO clearly says 150 milligram. So there are no clear guidelines who to give 75, who to give 150. But if the risk factors are significant, this is what we do in practice, 150 milligram is preferred. Okay, especially if she has significant high risk factors. But nowhere is it actually mentioned who to give 75, who to give 150 if you're talking about recommendations. So the higher the risk, 150 would be better. And if the risk is lesser, then 75 also should suffice. The aim is to start it by 12 weeks of pregnancy because that is when the second wave or invasion would happen.
Okay, ma'am.
Yeah, okay.
Thank you so much, ma'am, for your time.
Thank you, ma'am, for your time, for your sharing your wonderful knowledge. We want more session from you in future, ma'am. Thank you, ma'am.
Definitely. Thank you.
And
Thank
wonderful
you,
case presentation by Dr. Tanvi. We learned a lot from this. Thank you, ma'am.
Thank you.
Bye.